So this is a patient that we had at the Minneapolis VA Medical Center, and Dr. Kelly is a surgeon who was involved, and we had the IR people involved also, along with the interventional cardiologist. So this is a 72-year-old patient who presented for an elective RCA stenting. He has history of CKD, diabetes, AFib, coronary disease with grafts to Lima LAD, SVG RCA, SVG to OM and D1. Other expected history from veterans' history, you can see hypertension, hyperlipidemia, PAD, and his EF was actually 60% when he came. So this was his left-sided angiogram, and you can see his OM was stented, even though he had a graft that was occluded, and he has good Lima backflow that you can see in the second picture there on the right side. This is his RCA, first injection, and you can call it close to subtotal. The right side has some flow and is a diffuse long lesion and some bridging collaterals. And this is the result on the right side after we stented the prox through the mid and distal RCA. Any comments post-stenting? Anything that you notice unusual? No? Okay. So that's just the graft flow back you can see here. So patient continued to have chest pain, did not improve after waiting for 30 minutes in the cath lab. When the patient came in, he had a stable angina presentation, but after we did the stenting, we had to wait for 30 minutes, but still pain didn't resolve with all the medications. His blood pressure was looking okay. So I showed you the angiogram. We saw the jailed marginal branch, and then that supplied a small portion of the inferior wall, and this is the one that I was talking about, the one on the right side, if you see, the jailed marginal, and it does supply a small part of the inferior wall. I couldn't find something else that would contribute to the chest pain. So we noticed while doing the procedure, the whisper wire to access marginal branch, we had to go through the stent struts, and we found balloon dilatation with a 2 millimeter balloon. And so the wire briefly entered the tiny side branch, not the main marginal, but you can see the side branch that's starting above from the marginal branch right here. And that the wire entered that branch and almost 2 to 3 centimeters, and this wire was withdrawn, and we took a final angiogram picture. And we didn't see anything after that, so we were very convinced that everything looked okay, and we sent the patient to the floor. So after 5-10 minutes, the patient was taken up, and he continues to have chest pain. The EKG is completely different from what he had before, and you can see inferior ST elevations, also V1 ST elevations there. And this is his ultrasound that we did bedside, and you can clearly see there is expanding hematoma on the RV side, and this is compressing your RV. And I got a short axis view and a parasternal long axis view, you can see. And this is the RVOT, and obviously there is no flow from his RV outside, and there's a big hematoma. It keeps expanding. It started like a very small one, like 2 centimeters or something, and then it just kept expanding. And you can see here, the RVOT is almost completely compressed. There's no flow. And as expected, the patient is dropping blood pressures in the 70s and is obtended, and he was started on dopamine, epinephrine at that point. So he was taken immediately to cath lab. It's very tricky. You can't do the regular pericardiocentesis with the apical axis because there's no fluid collection at the apex. And it's all left parasternal, and the only window you could see is above the RV anterior, so we had to go for the left parasternal window for epicardial axis. And we used a stiff amplatz wire because it's a lot of coagulum blood accumulation, so we couldn't really force a regular wire through it. So you had to use stiff amplatz for that to advance pericardial pigtail catheter. Once after we got that in, we almost got 350 cc's of blood. I said 300, okay, but 350 cc's of blood, and the pressure, it was immediate pressure recovery following pericardiocentesis. And I just want to show you the picture on the right side, which should have come after the next slide, but you notice anything unusual here? What is that? I'm sorry. Yeah. So this is like the normal graft flow, but this is where you notice something. You see a myocardial blush, you see some pulsatile flow right there. So this is obviously a perforation that happened. And this is the angiogram that the same thing that I showed you. You can see the perforate there. So obviously we went with the wire. We went through the RV marginal branch. As we clearly see, it's we thought like we went to the wire, the side branch here, and probably that's perforating. So we wanted to occlude that, and we ballooned it nicely for some time. And even with that, you can still see the myocardial blush, and still the perforation still filling. So any suggestions what to be done next at this point? Right. So it's a very good thinking. So this patient. You can see this, it's important to notice in patients with chronic subtotal occlusion, I'm just showing this squiggly line here, just to show you the collateral that arises from here, and it goes all the way above to see the small branch down there. So this patient obviously had subtotal occlusion, and he developed bridging collaterals from the proximal distal branch or between these two branches, and obviously that's another feeding source that you could expect causing your expanding hematoma even after trying to occlude your RV marginal branch. So we try to go with the balloon, just do the same thing there, and once after balloon, we try to inject, and you still see leaking down there. So we balloon this, we balloon that, and you still see this. So there's like, if you occlude one, it obviously increases the pressure on the other thing, so it increases the flow and causes more accumulation. So it's like increasing the resistance at one point, and then it builds pressure and it leaks more. So obviously we decided to go and fix both at this point. And that's why we got a picture, and you still see the myocardial blush and the perforation down there. And then we went preparing for deploying retrievable coils down there. And, and you can see this picture on the right side showing the coils deployed to the RV marginal branch. And at that point, you could still see the myocardial blush, so we decided to go and get the other one from above, the small branch that we talked about. I'm showing you the same pictures just to show it's still blushing, a lot of flow. So you can see we deployed now retrievable coils in this small branch above and then this branch below. So at this point, we were very convinced there was no residual flow. There's no blush that we kept seeing here. I mean, this little flow, I don't know, I'm not very convinced, but that was actually really a lot before we closed this. So after this was done, and obviously, when someone is bleeding, we cannot, we just put in stents in this patient. We cannot be using anticoagulation. Very high risk of stent thrombosis. So it's a major risk when somebody is perforating and bleeding. You cannot use anticoagulation. You're risking a stent. So mid-RCA, we had to pre-dilate with a 3 millimeter balloon, and we had to put a stent because we had a thrombus at the site, and I'll show you the picture of the thrombus. And then we post-dilated with 3x8 balloon. And we saw some thrombus migrated to the AV groove segment, the PDA branches, and we couldn't do much about it. We just used a daughter and inflated 8 atmospheres there. And you could see small emboli, as I told in the distal part. And this is just the ballooning part I'm showing. And this is the final angiogram. And you can see this vessel had a good flow in the beginning, and this is thrombosed at this point. But all we could do is just fix this thing again, the thrombus. And now this is a post-Cath echocardiogram. And this is just an artifact, you see. It's a range ambiguity artifact. It's nothing different. But you see the RV is completely expanded at this point. And this is another view showing RV is down. The function is definitely down. But overall, the expansion is not there anymore. So important take-home points in this case is coronary perforation is associated with poor outcomes. So definitely don't aim for perfection. I don't know, we were debating for 30 minutes, waiting in the cath lab, trying to see if we should fix that or not, and finally went ahead and just ballooned it. And I don't know if that probably started everything. And localized pericardial effusion after cardiac surgery could be rapidly fatal, any cardiac procedure, I mean. So your conventional access may not work all the time, so you have to think about unconventional access using stiff wires for getting precondition. This is using a parasternal space, as we were doing in our case. With prior severe occlusion, subtotal, beware of collateral circulation causing perforation and leaking around, so you have to go get both fixed at the same time. And anticoagulation, now, obviously, now is challenging, cannot use it in a covered stent to cover perforation sometimes can be life-saving in this patients, but obviously leads to a iatrogenic myocardial infarction in the territory that the vessel is supplying. All right, that I'll stop and I'll open for questions, and thanks a lot for the opportunity, and thank the moderators and chairpersons for inviting us here.
Very nice case. Any questions from the audience about this case? Go ahead.
I do not understand the cause of the perforation was your attempt to open the acute marginal branch after PCI, or was something that happened during the CTO of PCI that you didn't do?
No, the thinking process is, I think after we're done with the stenting, we just went ahead and dilated the marginal branch, and then we noticed the wire, whisper wire, actually, while getting back, it was once advanced to the small branch coming from the RV marginal branch. So we think that's probably what caused everything.
Then you had continuous flow because this was used while on CTO on the collateral.
Yeah, from the collateral. So we thought, like, so we were trying to occlude this for a long time and didn't help. Still a lot of flow, and actually more flow after we tried to occlude the balloon. So we assumed there was collateral flow, and I don't know, like we were increasing the pressure on one side and building pressure and leaking more from the collateral itself. That's the thinking process. I mean, it's complicated to think when you've already opened up your right side and there's good flow now down there. So it should actually be lowering your flow than when you had a CTO before. But for some reason, it's bleeding more. We tried to balloon that marginal branch.
Great case. The one thing I was going to ask you is, I'm not sure, once you've gotten the pericardiocentesis drain in place and taken her back for the second look, would anyone consider giving her heparin, sort of a low dose, just to prevent the thrombus that's sort of over there?
Right. I mean, it was a very significant thrombus we saw. It was like we were devastated looking at the nice stent and then finally saw like multiple thrombus. But we were debating a lot with the rate of bleeding, and the patient was almost dead. He was uptended. He had to intubate, and pressures were in the 70s. So we were like just risking his life. We thought at this point it's okay to compromise his complete RCA. And